Good afternoon. Welcome, everyone, as we continue down our mini webinars on understanding antipsychotic blood levels. I'm Megan Arrett, faculty member at the University of Maryland School of Pharmacy, and I'd like to give a warm welcome to our expert today, Dr. Jonathan Meyer. He is a clinical professor of psychiatry at the University of California, San Diego, distinguished fellow of the American Psychiatric Association, and a former colleague on SMI Advisor and an expert in all things antipsychotic levels. If you haven't gotten the books, you should definitely look into those. Are very useful resources. I'm going to turn it over to you, Dr. Meyer. Anyone during the presentation, please use the question and answer feature at the bottom. We'll get those questions over to Dr. Meyer at the end of his presentation. So thank you so much for your attendance today.
Thanks so much, Megan. Thank you all to sharing what your lunch hours, if you're on the East Coast, or for like you who is on the West Coast, your morning coffee break or whatever the heck you're doing at 9 a.m. This is what we're talking about. And I think in many ways I'm preaching to the choir. I think you all understand the value of drug monitoring. It just has not been applied as much in this context of antipsychotic levels. This is me, as Megan mentioned. Here's my disclosures. Most importantly, we are going to be talking about an FDA-approved assay called Meyer, and it's about particularly this topic is about drug levels, but part of the big issues which we'll discuss is the way labs really have homegrown assays, and it's nice that we finally have an FDA-approved assay, which is manufactured by Salinex, who is compensating me for my time. So, what's our objectives? Talk about level monitoring of antipsychotics, which is not commonly done, or if it's ever done, it's only done for clozapine. And I'll just reinforce some basic concepts regarding antipsychotic levels, such as the therapeutic threshold and the point of futility, which is really the upper end of the therapeutic range, and get into a little bit about how we interpret levels in the context of the clinical assessment and when to act on levels, especially when they're high. Well, why should we get antipsychotic levels? Well, there's a basic reason, in case you all don't know, which I think you do. Occasionally, people don't always take their oral medications. Occasionally, not my patients, of course, but I hear stories. When economic analyses have been done, given the fact that, especially in the world of schizophrenia, the consequences of non-adherence are significant, even a decade ago, you could say $1,580 per year per patient by improving adherence through drug level monitoring. Also, even when people are adherent with oral medications or they're getting their medication via long-acting injectable, there's significant population differences in drug metabolism. And especially when people aren't getting better and you're not sure why, or they're having unusual adverse effects with relatively low exposure to the medication dose and you're not sure why, you have to figure it out so you can make better decisions in the future. There was a consensus paper which came out in 2020, which was a joint statement between the American Society of Clinical Psychopharm and a group in Germany who's been publishing papers about every 7 years for a couple of decades on therapeutic drug monitoring of psychotropics. Why would you get an antipsychotic level? Well, here's about 15 reasons. I think the idea, again, is even when people seemingly are stable on oral therapy, they may not be adherent. I would say maybe the one reason I would never get a level is if I've had somebody on LAI, stable dose for years with no adverse effects. I guess there's really no point. But for most human beings, there really is a point in getting drug levels. Why have many people not incorporated antipsychotic levels in particular into their practice in the way they might, let's say, for a valproate level? Well, for one thing, you have to get levels typically 12 hours post-dose if they're on oral therapy. That's actually not the hugest problem, but the big issue is the turnaround in the past has often been quite slow, which means you have to make clinical decisions in the absence of the information. Now, eventually you'll get the info from the lab and then you can modify your future behavior, but it's a little frustrating to clinicians that it takes so long to get a result back. And the reported results are really specific to the lab which is used. We'll talk about that in a second, but the problem is each lab creates its own reagents and therefore often sometimes reports level ranges which are unique to that lab. There's no standardization, and I'll give you a great example of that in a second. It's a huge problem, and it's unique to antipsychotic levels more so than any other psychotropic, and really almost any other analyte I've looked at, where you see these enormous variations in what they might call the therapeutic range. And the fact that until recently there was no FDA cleared test means that it's almost impossible sometimes to compare results between laboratories. And the lack of that standardization is, again, another big problem for the industry. We have a solution to part of the problem with respect to clozapine with this new immunoassay, but that is not true for every other antipsychotic level. And then clinicians just don't know how to use levels. A question I get all the time in part of my work at the state hospital is, okay, look, this guy's not responding to 20 milligrams of haloperidol at night. I'm going to get a level. What do I expect? What do I even do with the number? They just don't know. As I mentioned, one step in the right direction is an FDA cleared immunoassay, and we think this is the wave of the future. The important aspect about this is that every lab is doing the same assay. You can now compare results between labs. The consistency across sites is really important. The other thing is that because the module which is used is added on to the standard laboratory analyzer, you get your results back within hours, not 1 to 2 weeks. Now we can incorporate the clozapine level into real-time decision making. People come to the clinic in the morning, you can get a level, you'll have that level back by the afternoon like you do for many other labs, like a lithium level, and then you can make adjustments. Somebody comes to the ER with an issue, you can get a clozapine level in real time, make appropriate decisions. Again, there's still issues. You want to get the lab usually 12 hours post-dose. This is true even for clozapine, and people need to be educated about how to respond to these levels, which is somewhat of what we'll get into. And lastly, once you can get these levels in real time, you have to figure out the best way to work it into your workflow. The LCMS is considered the gold standard as a method, but the problem is, in particular, every lab creates their own reagents, and there's a lot of variability between labs. I noticed this even within a single lab. What we often find at the state hospital is that each hospital will use its own local lab because California is so big. We know when the laboratory technician who normally does the clozapine assay goes on vacation, because all of a sudden the levels, which have usually been in a certain range for a patient, are now twice as high, and yet there's been no dosage change whatsoever. We know exactly what's going on. It's very frustrating, but because of our experience in this area, we can make sense of some of these wild numbers because we appreciate what is going on in the lab itself. The one advantage of the LCMS when the result is accurate is you do get the metabolite, although that's not always necessary, though sometimes there's issues when it can be. But the turnaround is quite slow. And when you don't have the A team as the technician running the assay, sometimes you get results which are almost uninterpretable, and this becomes very frustrating. The beauty of the FDA cleared immunoassay is you get the results in real time. It's fully automated. It goes right on the lab analyzer. You have great specificity. You have great inter-laboratory correlation. And that's really helpful in case you use a different lab. If they have this same assay, you know you're going to get the same result. And this is showing you some of the variability between labs with the LCMS versus the immunoassay. And this is the problem. It just becomes a big, big issue when you change labs for getting this. And I can say even within the same lab, the interassay coefficient of variation can be quite problematic. Like I say, we get the B team on covering vacation for the usual technician, and all of a sudden these clozapine levels, which are 850, are now 2000. We know nothing has changed with the patient, and we know exactly what's going on, but it really, really becomes a source of consternation for the clinicians. The fact that the immunoassay doesn't give us norclozapine is perhaps one limitation, but we've come to appreciate, and I wrote a paper on this in the past year, that the value of norclozapine is in certain circumstances. We don't peg efficacy to norclozapine levels or the sum of clozapine plus norclozapine. we think efficacy correlates best with the clozapine level. We sometimes want the metabolite if we're trying to figure out why somebody might not be getting the level we expect for a given dose of clozapine. And you're wondering perhaps, are they an ultra rapid metabolizer? That's really probably the most important use of the norclozapine level. But in general, we make all efficacy decisions based upon the clozapine level itself. And we'll bring in the metabolite in certain circumstances where we need to get some additional information. This is the party line on antipsychotic levels. Yes, I understand we give most antipsychotics, which are oral, once a day at bedtime. And the true trough, of course, will be 24 hours later. But no one's going to get levels at 8 o'clock at night. And the field with psychotropic level monitoring, regardless if it's an antipsychotic or lithium, gravitated many decades ago to a 12-hour level as the standard. That's where the literature is largely built around, is results from 12-hour levels. And it was done really for feasibility purposes. But importantly, sometimes you'll hear from clinicians, even though they know their antipsychotic has a half-life in the brain of more than 24 hours, that they like to give, haloperidol 3 times a day. Even clozapine doesn't have to be given multiple times per day, although it's in the package insert. Well, one reason we discourage people from giving antipsychotics multiple times per day is not only because of the issue with getting a level. It's not going to be a 12-hour level for most of those doses if they're taking it TID or even BID. It's going to be a 12-hour level for half the dose. But also, when you give strong D2 blockers in the morning, or even clozapine in the morning, you really diminish tolerability significantly. And I give you this data here from the pivotal trials of lorazepam. When they gave it in the morning with a morning meal, the rate of akathisia on 120 milligrams was 22%. When they moved it to an evening meal, they could even give a third higher dose, but the rates of akathisia went down by 2/3. It's a great reason why, even on inpatient units, you really should not be giving antipsychotics multiple times per day. You don't improve efficacy, all you do is increase rates of adverse effects, especially D2 related. If you're on an LAI, we typically get your trough level just before the next injection, literally just before, maybe a few days before, and that's considered the low point within the therapeutic range for that cycle. So what does the level mean? A couple of comments here. It's really hard to figure out if people are adhering with oral medications. I sometimes hear clinicians say, well, she's been showing up to her appointments on a regular basis. She hasn't been in the hospital for 2 years. She must be taking her oral antipsychotic. And the point I make with them is you have no idea what they're doing. All you can say is she takes enough medication to keep herself out of trouble and to show up at her appointments. You really don't know what the level of adherence is. And of course, getting levels as quickly as possible really helps making better decisions. But when people are stable, I often encourage clinicians to get levels, especially for oral medications, simply because adherence is dynamic. People may be adherent now, they may not be next month for a variety of reasons. When you get outpatient oral levels or even inpatient oral levels, which are about 12 hours, there's always going to be a certain level of variation between assays. And I mean for that individual person, you'll see about 30% coefficient of variation. Why is that? Well, maybe every level is not exactly 12 hours. They took the dose a little bit later, a little bit earlier. There's a certain level of lab variation as well. The point is you expect a level of noise, but this is really part and parcel of what happens with oral levels. If you see big jumps between levels of 50% or more, this is usually representative of an adherence problem. The big issue with labs, which I talked about, is they all have their own reference ranges, many of which are not evidence-based. And the point is what they say is the upper limit is often pulled out of the mists of history with no justification. And we really encourage people not to overreact when you get a level which is above the upper limit of the reference range for that lab. The most important thing when people consult us at the state hospital and say, oh, this person's clozapine level is, quote, too high for that lab anyhow, or the other antipsychotic level is too high, is how does the patient look? There are lab errors. The most important question is, how does the patient look? And based upon the patient status, does this level even make sense? If the person is tolerating that level, then you have some time to figure it out and reason. Is this a lab error? Is this just a person who tolerates high levels? Maybe you're not sure, but we try not to overreact to a single result, because if the person's tolerating it, there is no emergency, and then you have time to figure out what you need to do. Well, here's the one reason we get antipsychotic levels on oral medication is many people are not adherent. Again, not my patients, but other people's patients. Well, there's a lot of ways we can track adherence. If you're doing a research study, you have a MEMS cap, but that's great. Right now, it's not available commercially very easily. I think there might be workarounds. I hope at some point it would be. Wouldn't it be awesome if every time your patient opened up their pill bottle, that information got transmitted maybe via their smartphone to a portal on the web? It would be pretty cool. Pill counts, definitely evidence-based. Third-party information is somewhat helpful, but the best and most practical ways of tracking oral medication adherence are pill counts, number one, and plasma levels, number two. The worst way to track adherence is to ask the patient, are you taking your meds? That's a bad way to ask about adherence. And your own self-perception of the patient's adherence. Again, many people falsely correlate stability with adherence. The two are not necessarily correlated at all. This is data from studies which used MEMS cap technology. And all they asked the patients was to take their medications 70% of the time. They didn't have to have 100% adherence, anything above 70%, which is more than 5 days out of 7. Well, the MEMS cap doesn't lie. MEMS cap said the rate of non-adherence, or the rate of adherence rather, was 43%. You ask the clinicians, because they know their patients, oh, they like me, I have good rapport. Of course they take their oral medications more than 5 days out of 7. Yeah, well, you're way, way off. And asking a patient that same question often doesn't give you a really good answer. And two reasons why this is so concerning is, for one thing, you may falsely assume someone is adherent and don't react appropriately when they become symptomatic. Also, if the person is symptomatic, you might assume incorrectly that they are a medication failure and think they need clozapine. As Megan somewhat jokingly showed you, I've written a book on how to use clozapine, and I love it a lot. But you can see from the bullet on the left, this is data, the second bullet, from an academically affiliated community mental health center in London. They found 99 people who were going to be referred for clozapine. They did drug levels on them, and shockingly, 35% were subtherapeutic. And among that 35%, a third of them had undetectable levels completely. The point being is you cannot make good decisions in the absence of levels. And even when people are stable, it helps give you a baseline so that when things change, then you have a point of reference for deciding what to do. And this is exactly what I'm talking about. This graphic comes from a paper. Patients were followed on their oral second generation antipsychotic over a year. And you can see, look, we like to think every one of our patients is curve number one, but it can be anything. And because someone has been adherent for a while is no guarantee of future behavior. The nature of the beast with chronic illnesses requiring oral therapy is oral medication non-adherence. Doesn't matter if it's schizophrenia or diabetes or hypertension, people don't take their oral medications all the time. The difference is I don't take my antihypertensives, I probably won't suffer any immediate consequences, not for a long time. If I don't take my antipsychotic, I might be in the hospital next week. Now, maybe not. Maybe it'll take a couple of months, but the consequences are so dire. And I think one thing we've all come to appreciate more than anything is that each episode of relapse related to non-adherence pushes the patient incrementally towards being a medication non-responder. And that's not reversible. It's one reason we try very hard to get folks on long-acting injectables is to minimize the relapse risk and the brain consequences of relapse. When we get 12-hour levels, there will be a certain level of variation. So here's the intra-individual coefficient of variation for inpatients. You can see it's pretty tight. This is an old study, but the methodology is sound. Once they went to outpatients, you can see that CV goes up. That's why I say, look, if it's something around, up to 30% variation, it's kind of what you expect, and don't overreact to that. However, once you see levels drop by more than 50%, you know there's a problem, and it's usually one of adherence, unless there's some unusual circumstance where an inducing agent has been um, thrown into the mix. What would be an inducer? Well, pharmacologically, some of these old drugs like carbamazepine and phenytoin, maybe in the modern era are rifampin. With respect to clozapine, the number one inducer out there is cigarette smoking, and you literally have to burn the leaf. Burning the leaf generates aryl hydrocarbons, which induce 1A2. Here's a graphic of somebody who had levels checked roughly every 6 months. And I think that's a reasonable interval with oral therapy. We do that with oral mood stabilizers as well. Why do I get a valproate level for the few people left on it? Is to see if they're taking the darn thing. That's why. Her levels were relatively stable. She'd gotten out of the hospital. We checked them, and then one kind of dipped a little bit. That was the point where we had a discussion about what was going on. The best way to ask about oral non-adherence is to normalize it. We know that many people are non-adherent. I never ask the question, did you take your meds? It's such a stupid question. You know what the answer is going to be. Who's going to look in your face and say, no? A better question is to normalize it. And I usually phrase it in the way that I say, look, many people miss doses of medicines. It happens all the time. How do you think you may have missed in the week or so before you got that level? And they say what they say. I don't believe them, but they say what they say. And I exhort them, do better. This patient refused an LAI. I didn't have a choice. She said she'd do better, did better for a while, then finally she dropped off. Became very symptomatic. We didn't have to admit her, but we did talk her into an LAI at that point. But this is why you get levels periodically, so you can pick things up before it results in hospitalization. So here's an example. This lady was sent out of the hospital on 20 olanzapine at night. Looks good for a while. Now she's more symptomatic. Of course, she denies that she's cheeking doses or missing doses. She was out of board-in care. She denies substance use or new stressors. Of course, this is the future when we can get everything we want instantaneously, and we happen to get a 12-hour level back, which is 15 nanograms per ml. That's great. Of course, the question I'm asking you is, what level do you expect for somebody on 20 milligrams at bedtime? An important question. A good rule of thumb as medicine is don't get a test unless you can interpret it. I'll tell you how to interpret it. And these are the types of correlations which have been published, which I summarized in a book, but you could find the individual studies yourself. If somebody's on olanzapine, I'm always showing you the second half of the alphabet. I hid the first half of the alphabet, which has aripiprazole through, I think, haloperidol. And that will be in the handout, which you can download. If you're on olanzapine and you're a non-smoker, your 12-hour level is roughly 2.0 times your oral dose. If you're a smoker, it's going to be a bit less because one of olanzapine's pathways is through 1A2. It's actually not the major pathway. Its major pathway is phase 2. But non-smoker, 2 times the oral dose. All right, this lady's on 20 QHS. She's a non-smoker. We expect her 12-hour level to be around 40. Let me tell you, 15, nowhere near 40. Also, we have clinical information. This person now appears more symptomatic. You know what's going on. You know she's non-adherent, and now you have a number to quantify that. What do? Well, we have the discussion. We say, look, your level seems a little low for this dose. We'd like to check it again. It may explain why maybe you're doing a little bit worse. And let's see if we can do things better. Now, in this day and age, we don't really have a easily used form of long-acting injectable olanzapine. That will change. That will change within the next probably 6 to 9 months when we'll have a long-acting injectable subcutaneous form of olanzapine, or so we hope. And that'll solve one problem, which is not solved by the intramuscular form of LAI olanzapine pamoate. But for the time being, if this lady needs olanzapine, all we can do is say, do better, and most importantly, we'll recheck her levels. Some other concepts on non-adherence is that when a level is low, you got to figure out why. Yes, it's often non-adherence, but especially when you don't have a baseline, like for the case I just presented, you got to figure out what's going on. Number one, always look at the time of the blood draw. I get people who call me up, oh, this lady's lithium level is low, it's 0.4. The first question I ask them is, what time of the day was the level drawn? Oh, 3 p.m. I don't know how to interpret that. When did you take her dose? Oh, 9 p.m. the night before. Well, of course it's low. This is not exactly a 12-hour level. Figure that out. Make sure if the person's not self-administering meds, or even if they are, they're taking the right dose. You know, maybe when we went on vacation, somebody slipped them some carbamazepine. Not commonly, but just make sure there's no inducers which have been added to the mix. If the level is low, it may not be due to non-adherence when you don't have a baseline. I always will discuss adherence concepts non-judgmentally in the way I presented previously, and then I try to figure out what's going on. The point being is, with one low level, you're not sure. You get a second low level, which is very consistent, meaning the variation is very small from the first level, and it's likely this person might be an ultra-rapid metabolizer. There can be another reason why sometimes we see low levels, especially with clozapine. There's some people who don't absorb the drug very well. But once you get a second level, you'll know exactly what's going on. If you see big jumps in the level, it's an adherence problem. If the levels are consistently low, the person is either an ultra-rapid metabolizer or with the concept of clozapine, they are not absorbing it. Now, as we titrate people, we have to make decisions based upon how they're doing clinically with respect to what's going on with their level as well. The response threshold for antipsychotics is that point, usually done based upon mathematical analyses called ROC curves, which separate true responders from non-responders or false positive responders. Most of these are done from double-blind fixed dose studies with an acute exacerbation of schizophrenia and almost exclusively in adults. We can often infer what the response threshold is for antagonist antipsychotics based upon that plasma level associated with 65% D2 receptor occupancy. The point is that there's a range of levels in the literature, and at some point people tend to glom onto or gravitate towards one number. There's no right answer per se, but over time you pick a number from the literature, and I'll give you some values, which we'd say this is reasonably evidence-based, and this is the point which I can use in my mind as an initial target for a level when the person is not responding. For clozapine, we've tended to use 350 nanogram per ml as the response threshold. What does that mean? Well, look, there are people who respond below than 350, just not many. And nobody's calling me up from the state hospital saying, my God, what do I do? This patient's doing really well with a level of 285. It's not why they call me. They call me because the patient is a non-responder, and then the first question I'll ask is, and what is the clozapine level? And they'll say it's 325. I'm like, yeah, you're probably just not in the ball game yet. Let's start to get above 350. Again, being above 350, there's no guarantee of response. Maybe that person's brain doesn't need a level of 352. Maybe they need a level of 825. But it maximizes your chance of converting a non-responder to a responder. And that's the way you look at it. That's the clinical context of using these therapeutic thresholds. It's a target. It's a target for people who are inadequate responders, and certainly for those who are still tolerating the medication. And here's a consult I got. Somebody was on clozapine for 4 weeks. Their level is 302 nanogram per ml. Their dose is 300, made perfect sense with the dose, what the level was, no limiting adverse effects. They said, what should I do? And our response is, give them more. You're not even in the ball game. You're not even at the response threshold. And again, the point where they might respond is unknown for any individual, but let's kind of get them up there, and then we'll figure that out. One thing I really encourage you to do, because you are often the sources of, I would say, intelligent information about how to interpret plasma antipsychotic levels. What I encourage you not to say to somebody if they come to you and say, oh, this patient is not responding to a clozapine level, let's say of 550, don't say, oh, that level is therapeutic. Well, if the patient is a non-responder, that level is not therapeutic for them. The point being is that where in the range this person may respond, if they respond at all, is unknown. But if the patient is a non-responder, don't say, oh, that level's therapeutic, because what will happen is the clinicians will incorrectly conclude, if I get above 350, even nominally above 350, the person doesn't get better, that's it, my work is done because the level is, quote, therapeutic. A better way to talk about levels is to say, is the person a responder or not, and where is the level in the range? If the person's a non-responder, that is the most important concept. And what I say is, oh, that level is not therapeutic for them. And our appropriate decision will be, unless there's dose-limiting adverse effects, let's give them more, up to a certain point. And we'll give a name to that upper limit, and we call it the point of futility. As patients are titrated on oral medications, one thing we've learned over the last 20 years is that most of the improvement with a dose change happens within the first 2 weeks. And this is true even for clozapine. But the idea is if somebody comes to you and the patient's been on an oral dose for a couple of weeks, at least as far as they can tell, they are taking it. If you've achieved almost nothing in terms of benefit, less than minimal improvement, they are unlikely to be a responder at week 6, and it's time to move along to the next dosage increment unless tolerability is limiting. But don't necessarily let people sit on a dose which has shown no response for 6 weeks. That old saw that 6 weeks is, quote, an adequate trial of antipsychotics is completely wrong. What fails is the dose, and the point at which you can make that determination is after 2 weeks. We call it the 2-week rule. And then guess what? It also applies to antidepressants. Now, LAIs work on a very different time frame, and you'll have to make your decisions based upon when levels will be peaking after the injection and are you at steady state. A little more complicated, but not impossible. And this is the paper that was published 20 years ago by Ofer Agid, showing that most of the change in positive symptoms for a given dose happens within the first 2 weeks. And the point being, if somebody's been on a dose for 2 weeks, that's when they should be reassessed. If they've gotten minimal improvement, I mean less than minimal improvement, it's time to move along, assuming they're taking it. And again, that's why you sometimes get levels. You think, gosh, this person's on 6 of risperidone. How come she's not better? Well, maybe she's not taking it. And yes, might I go up higher in the dose? I might, but before I do that, I really want to get a level to figure out what is going on here because something is not adding up. Yes, there are people who tolerate lots of D2 blockade, but you would expect some movement on that dose of risperidone. Here's a great example from a clozapine-treated patient. Again, the response threshold is 350 nanogram per ml. This person got titrated to 300, the case we talked about before, didn't get better on 302 after a month. No dose-limiting adverse effects. We said, look, move along. Let's get them up to a higher dose with a higher level. A level comes back after a week on 400 QHS, and that level is now 432. But the patient seems no different. And the treating psychiatrist said, what do I do? Should I go up? Is it too soon to go up? Well, people have analyzed this for clozapine. And the reason I harp on clozapine in particular is that there was this old mythology of, quote, late response in clozapine. Let me tell you, it's absolutely untrue. And how do we know this? Because of this study done by Rob Connolly at the University of Maryland, which is Megan's home university. They took people in the state hospital who were clozapine candidates, and they had a titration schedule which they followed. And then they waited several weeks between each titration before they moved up the next unit. They gave people enough time to respond. What they found is that among those who did respond to clozapine, the average time to response after a dose increase was 2.5 weeks. Very much in line with other antipsychotics. You can see the standard deviation was 14 days. The point being is that even with clozapine, you do not let people sit for weeks and months on a dose with minimal or less than minimal response without taking action. And I encourage you, if you're overseeing a clozapine clinic or inpatients who are being titrated on clozapine, to make these assessments sooner once you get people at least above the response threshold. If you bump up somebody like this case here, who's bumped up to a dose of 400 with a level 432. They said, what should I do? We said, 1 week is too soon to make the assessment. Give this patient another week. If you see less than minimal response with a plasma level of 432 and there's no limiting adverse effects, then move them along. Go up the next increment. If you want to go up by 50s, that's fine. But make your assessments roughly every couple of weeks. Don't wait months for a quote late response. It does not exist. And they saw none of that in this titration study. Well, eventually the person doesn't get better and trying to figure out, should I just stop? Why would you stop titration of an antipsychotic? Well, one reason is people get better. Occasionally that happens. Sometimes we're lucky, even me. Or they can't stand it anymore. This often becomes the issue for D2 dependent antipsychotics. Whatever magic clozapine has, it's not related to D2 occupancy, but really every other antipsychotic. That's the primary mechanism of action, and that often becomes the limiting adverse effect. The other one will be the upper limit, which I'm going to call the point of futility, and I'll explain why in a second. And there's the unusual aspect of clozapine and some other drugs where you can only give so much. No pharmacy or very few pharmacies will dispense more than 900 milligrams a day of clozapine, and that often becomes the point where you say, I just cannot go any higher. But if none of these criteria are met, it's time to keep moving along. If the person is not better and they don't have intolerable adverse effects, and their level is not yet at that point of futility, it's time to keep titrating until you meet one of these hard endpoints. Part of the issue, though, for many clinicians is deciding where that endpoint is. And one of my motivations for publishing a volume on antipsychotic plasma levels is exactly this kind of nonsense we see out there. You say, why do I say nonsense? Well, look at the fluphenazine level. ARUP, big commercial lab in Salt Lake City, highly respected. They say the upper limit is 2. LabCorp and Mayo say it's 10, and Quest doesn't even give me values. How do I find this out? I went to their websites, got the values, and then I called each of these labs and I said, how did you come up with these numbers? And you know what the answer is? We don't know. Somebody somewhere in the mists of history had looked this up and they put it down, and they couldn't even tell me how they came up with these numbers. None of these numbers are evidence-based, by the way, none of them. And that's a huge problem. You see this range of variation and what somebody says is the upper limit, you know, this is not the way to practice medicine. It's a unique problem for antipsychotic levels, but that's really what I wanted to impart to you all, is you have to know this. Do not use the laboratory ranges for antipsychotics. They're grossly inaccurate and cause a lot of problems. I'll tell you, very few human beings will tolerate a fluphenazine level above 4. Why LabCorp and Mayo say 10, I have no idea. I mean, literally no idea. It is absurd, to say the least. The reason we call the upper limit the point of futility, and we really evolved this nomenclature within my work at the California Department of State Hospitals, the biggest state hospital system probably in the world, almost 7,000 patients, mostly schizophrenia spectrum, is that we had a bunch of clinicians who probably should retire who thought they could make everybody better if they just gave them enough haloperidol. And what they didn't appreciate is that there's some people, even with a potent first generation agent, who will never get D2 related adverse effects. And they kept titrating them and titrating them, thinking they'll eventually make them better. And they said, well, the patient doesn't have Parkinsonism. They don't have akathisia. I'll give them more. Well, guess what? There's a point beyond which you're not going to make them better. D2 blockade is not going to solve their problems. They need the magic of clozapine. You have to know when to cut it off, though, and stop wasting the patient's time. The point of futility really defines an upper limit where even if it's tolerated, going beyond it is fruitless, meaning your chances of converting a non-responder to a responder is less than 5%. And the levels which we've come up with as the point of futility map very closely to what the consensus paper laboratory alert levels were, meaning it's not inherently unsafe. Beyond that, you run into tolerability issues. And you may run into it before, which often stops the titration, but going up to these levels is not unsafe. And here's an example. This was a study done by one of my mentors, George Simpson, who's almost 100 years old, still alive, where they titrated people on a first generation agent, trifluperazine. They wanted to find out what was the range of doses which gave people intolerable neurological adverse effects. That's the point where typically in the past we would stop titrating a D2 blocker. Push somebody to the point where they got akathisia or Parkinsonism and then back off. They say, well, what's the range among human beings? Well, this poor gentleman, patient number 5, he was in the study for a long time, as you can see. They kept titrating and titrating. He had limited psychiatric improvement. He had limited neurological adverse effects too. You could see he had the lowest adverse effect rating and he gained a ton of weight. The point being is there are people out there who can tolerate heroic doses of D2 blockade, the equivalent I give you in the title 192 milligrams of haloperidol. I've never given anybody that much haloperidol. But the point being is there's some people who seemingly have limitless tolerance for D2 blockade, and they are never going to get better. And that is the point of why we came up with the terminology of point of futility. We had wasted this guy's time a long time ago in titrating drug. And had we been getting levels, we would have cut this guy off a long time ago and say, hey, look, we have nothing to offer you here. At this point, clozapine did not exist, but in this day and age, we would move him along to clozapine. This is the kind of curve we would like to have for every antipsychotic. This is based upon the early fluphenazine studies done in the late 80s and early 90s. You can see as you get to a level around 4, there's very few people, less than 5%, who will respond without what they call disabling adverse effects. And that's the point. It's just a waste of time. Even if the person could tolerate a fluphenazine level of 10, which is doubtful, the chances of converting them from a non-responder to a responder are less than 5%. It is a waste of time. Look at other options. Here's the numbers which I came up with for the points of futility. You can see for clozapine, I know labs say 600 or 700. It's not evidence-based. There's a lot of evidence to substantiate that there are people who do respond within the range of 700 to 1,000. Tolerability may become limiting. That's fine. But if tolerability is not limiting, especially if you're treatment resistant, you have little else to offer them but clozapine. Might as well keep titrating, manage the adverse effects, and see if you can convert this non-responder to a responder. And here it is for some of the other molecules as well. If I go back, you can see the point of futility for fluphenazine, based upon my analysis, is 4 nanograms per ml. That's what that graph showed you previously. For haloperidol, around 18 nanograms per ml. But I will say, I've received consults for people with haloperidol levels of 35, 54, 70. They really should have had that titration stopped a long time ago and moved on to something else, which probably would have been clozapine. So here's an example. Somebody, there's a state hospital patient, they were put on haloperidol, titrated to 25, 2 weeks, no adverse effects, but really almost no response. The plasma level is almost 20, and the clinician said, what should I do? Should I give them more? Look, some people tolerate higher levels, but the point of futility for haloperidol, by my analysis, is under 20 nanograms per ml, and we said this patient is not going to be benefited from more D2 blockade, even if they tolerate it. Time to move along, and most likely the only option you have is probably going to be clozapine, maybe high dose olanzapine. But more haloperidol is not the answer. And then lastly, this is often really a source of anxiety for clinicians when they get levels which are high. And what we have tried to really instill in clinicians is you always have to assess the patient. If the patient is an outpatient and you get a level back which is high, maybe their clozapine level comes back 1,500 and it used to be 800, well, call them up. Especially if it doesn't make sense, but you want to call them up and say, how do you feel? What's going on? If there's a caregiver there, talk to them. Hey, they look any worse? No, Becky's fine. She's having lunch. She drooling? No. She passed out on the floor? No. All righty. And then you go back and say, does this level even make sense? And here's an example. Again, this happened during a vacation. This is somebody who previously been on 500 a day of clozapine. Their level was 750. They were bumped up to 550 because they were a non-responder, and then the level came back 1,200. And the clinician called us in a panic. We looked at the meds. No other things have been changed. The patient looked the same. No med changes on inhibitors or inducers. We said, look, this is lab error. It makes zero sense. Document that you've assessed the patient, and then redraw the level tomorrow morning. And that's the most important tool in processing mentally and medical legally high levels. You must document what's going on. The first thing is you say, the patient has no adverse effects and the level makes no sense. Like the instance I just presented, I'm going to say this is lab error. I'm not going to change their dose. That's what we did for the prior patient. We said, leaving them on a dose of 550 a day of clozapine. This level makes no sense. This level should be maybe in the 800s, and we're going to redraw the level. Now, sometimes the patient has always had high levels. We get new clinicians to the state hospital. They're not used to dealing with sick patients. They draw a clozapine level. They hadn't looked at the prior levels, and the clozapine level comes back 1100, and they call us in a panic. We're like, well, did you look at the prior levels? They're always in the range between 900 and 1200. What's the big deal? Now, sometimes a patient had been ramped up too quickly and they really don't need a level that high. That's fine. But if you feel like you want to reduce the dose, if there's no adverse effects right now, think again. And think again if this is the way you want to go. And if you do it very, very slowly. Do not make big chunk drops in their dose. You're going to cause somebody to be destabilized. Maybe that person really does need a level of 1100. I had a patient as an outpatient at the VA here in La Jolla, which is a UCSD affiliate. This guy had never had a clozapine level checked. I got a 12-hour level. It was 1500. It made no sense to me. I assessed him. He was fine. I checked it again. Also 1550. And I said, you know, Mike, maybe you can do okay with a lower level. Guess what? He couldn't. I got his level down to 1000. He was much worse. I'm like, all right. And I think we settled on a level in the 1200 range. But you have to treat the patient and not the level. If the person does have adverse effects, find the prior tolerated dose and go to that dose and the level which corresponds to it. Don't make big cuts in their antipsychotic level simply because the lab says the upper limit is, you know, whatever it is. And then again, clozapine is the biggest issue. Many labs say the upper limit is 600 or 700. That's not evidence-based. 1000 makes much more sense. We get somebody who's usually on call, the level comes back 1100. They don't assess the patient. They don't look at prior levels. They just say, oh, the lab says the upper limit is 600. They cut the dose in half and the patient does very poorly. Do not make this mistake. If you can look and say, oh, the patient was okay with a certain dose and a certain level, and now they're having some adverse effects, let's just go back to the prior dose. That seems reasonable. You'll document your rationale. And then, of course, you'll order a repeat level about a week later. And here's an example. Somebody's on haloperidol at night. Plasma level is 21 nanogram per ml. Point of futility is 18. That lab at that time had an upper limit of 10. We don't know where they got that number from. What should be done? Well, the clinician asked us. We said, you know, there's no harm here. If you're unsure if the lab result is accurate, just recheck the level. And maybe if you say, okay, they're a little bit too high, perhaps you'll go down very, very slowly. 10% a month is actually somewhat aggressive. Even 5% is better. But don't do the, I'll say, the unintelligent thing. Don't cut their dose in half because the lab says the upper limit of 10. Believe me, that's their lab's opinion. I don't know where they got it from. The evidence is that levels closer to 20 are probably the point of futility. And even if the level was 35, we would still say you do not make big abrupt changes. You can destabilize people. You have to back out of this very, very slowly because of the phenomenon of supersensitivity psychosis. You expose people to high levels of D2 blockade, you can induce changes in their postsynaptic receptors. You cannot take away all that D2 blockade all at once, even if they didn't need most of it. You have to go down very, very slowly to allow some of those receptors to normalize and go from a supersensitive state to a normal receptor sensitivity to dopamine. Well, we think dose is not a great proxy for how drugs work, certainly oral medications, it's plasma levels. And we wish we had rapid results for all antipsychotic levels. We are fortunate now that we have one for clozapine, which is now standardized between labs because they all use the same methodology. But when you have people on oral drugs, you got to monitor levels. Non-adherence is common, it changes. Even when people are stable, you want to have a baseline, so if things change, you can make better decisions. Expect a certain amount of noise when you get outpatient levels, but if you see big jumps of more than 50%, it's usually non-adherence unless some new kinetic factor has been introduced into the equation. Understand some of the dose plasma level relationships so you can help clinicians decide, well, what level do you expect for a given dose? And really, really reinforce the concept that antipsychotics all generally work best given once a day at bedtime, including clozapine for most people, and we make all our decisions based on 12-hour levels. When people aren't responding, you got to figure out what's going on. Levels are your friend. Again, the therapeutic threshold is just an initial target. Don't tell people the level is therapeutic when the patient is completely symptomatic. Just say, well, you're above the response threshold, but this person's a non-responder. You can make decisions every couple of weeks on oral medications to move the titration a little more quickly than we did in the past. Know how to use that 2-week rule, and then also educate clinicians. Look, you can continue the titration up to what we would call the upper limit or the point of utility. Even if they tolerate the drug, going beyond that is really going to be a waste of time. And do not use the lab report as the only source of information for reference ranges for antipsychotics. They are grossly in error with a lot of contradiction even between labs. Find other sources of information, whether it's consensus paper or my book or whatever it is. But it's a unique problem with antipsychotic levels, but you have to know that. And hopefully, having heard it a couple of times here today, you can find ways to help clinicians interpret their antipsychotic levels and encourage them to get them, mostly so they can provide better care to their patients. At that point, I'm going to stop talking. So I'm going to hand it back to Megan. Thank you all very much. And I think we may have a few questions in the chat box.
Perfect. Thank you so much for this wealth of information. I'll remind participants, if you have anything while we're sort of talking here, please put that in the question and answer so we can get it over. So it looks like our first question is, can you clarify the comment about clozapine levels being significantly different within the same lab?
Yeah, unfortunately, the LCMS, technology means that every lab has to create their own reagents. And that's why you could take the same sample and send it to 2 different labs and you'll get widely divergent values. And that's the problem. The assays they're using are homegrown. The methodology per se is not homegrown, but the reagents and other components are. And that's why I give you the example. We see this all the time. It's usually around the Christmas holiday. The who does a clozapine assay goes on vacation, her replacement not as adept, all of a sudden those clozapine levels, and that's the one case I presented where the level on 500 was 750, and then they bumped it up to a clozapine dose of 550 and the level came back 1200. We knew exactly what was going on. It was December 23. We told the clinician, you got the B team there, they messed up with the reagents, they messed up with the methodology. And that's the problem. And that's the problem when you don't have standardized assay like you now have with the immunoassay for clozapine.
Yeah, it looks like this person had an example of they increased the dose, but the level dropped. And they had some switching to ODT because they thought they might be cheeking, but
Well, and that's a reasonable assumption. I mean, again, why do levels go down? It's almost always non-adherence. But there are, of course, differences between preparations sometimes. But again, if there's one low level, you're not sure, you get the second level, then you know exactly what's going on. If it's exactly the same, you'd say, okay, they're adherent and there's just different bioavailability for this preparation for some reason. I don't know why, but usually it's an adherence issue. Then you'll see a big jump and then you'll know what's going on. Usually the problem we have, Megan, with clozapine assays in particular, are ones which are extraordinarily high. We
yeah.
actually tend not to see the opposite. And that's just a unique aspect. We've seen that a little bit for haloperidol as well. One of our state hospitals switched vendors and all the haloperidol levels doubled. And we're like, okay, this is just a problem here for the lab. And it's unfortunate because it really makes a lot of headaches for the clinicians figuring out what to do.
Do you have any thoughts on recommendations? I know it's hard to know the lab and to have that familiarity, right? If you don't trust your lab, and especially since they're all homegrown reagents, how do you
Yeah.
go about?
Mostly, I would say if you get a level that makes no sense, I would just say try get it again. At least if the level is consistent, you say, okay, this person's on 400 of clozapine, they're a non-smoker, they're a male, so I expect their 12-hour level to be almost exactly the same as the dose. If it comes back 800, could it be possible? Sure. I mean, they really could be a poor metabolizer. I say just check it again. If it comes back the same, you say, okay, it is what it is. At least the lab has good intra-assay coefficients or inter-assay coefficients. So you say, at least they're consistent. What often happens is you have somebody whose baseline on 400 of clozapine is 450, and you're like, okay, it's been 6 months, I'll just recheck their level, which seems reasonable practice, and now it comes back 750. You're like, what the heck is this? Almost certainly it's lab error, and having a baseline really helps you make these decisions.
One of the other questions that we routinely get, and I know you spoke a little bit today about the 12-hour level, but what do we do with those pesky people that are still on clozapine twice a day and managing levels?
It is what it is. You just have to say, all right, it's probably a little bit higher. But if they really are wedded to the BID schedule, I wouldn't harass them. A lot of patients are really ill and with schizophrenia spectrum disorders, and if you change the color of their pills or the timing of their dose, it can destabilize them. Even though you think you've done nothing, it just becomes a source of psychological stress. I learned the hard way not to harass people too much unless there's a reason to do it. I may try to move as much as I can to the evening dose so that, maybe 2/3 of it, and I do that also for tolerability reasons. Unless they show preferentially, they just cannot get by with BID dosing. The norm in North America is to give clozapine almost all QHS, and that's been published. I try to do that. That's what we do at the state hospital. We tell people titrate at all QHS. The only reason you start adding in morning doses is usually for tolerability. You get to the point where they're like, okay, I go to the bathroom, I'm going to pass out. Fine, I'll accept that. So you just, yeah.
Is there an ideal time? Do you usually get the level before the morning dose, before the evening?
Yes.
Does it matter?
Yeah, usually the morning dose. That usually becomes what we usually do is we tell the person, hold your morning dose. If they're in a controlled setting or boarding care or a group home, we just say hold the morning dose, have Bob go to the lab in the morning, get his level drawn, and then when he gets home, just give him his morning dose. That's a big issue though, and that's another reason why you want to avoid BID dosing. And there's no efficacy advantage for most drugs. Clozapine is probably the one where we do it more so than other antipsychotics, but it's a big problem when people take BID doses and the level comes back high. It's like, did Bob take his morning dose? Oh, I don't know. We don't think so. You end up having to draw it again, and
Yeah.
that becomes another reason to avoid multiple daily dosing, just for practical purposes.
So in our last few minutes, one of the questions as we reach the point of futility, getting up to that 1,000 nanograms per milliliter, what is our next step? I know that's always a
Yeah.
loaded question.
Well, not really. This is what happens all the time at the state hospital. So the first thing is, and I don't want to be insulting, make sure the person has schizophrenia. Now you're thinking, well, we're not dumb. It's not that they don't have a schizophrenia spectrum disorder. Really, the big question is this person actually schizoaffective disorder bipolar type? Sometimes that history of mania has been lost because the person's been getting so much D2 blockade and people have forgotten that this person did have a history of mania. When you mood stabilize these people, they do much better. And in this day and age, lithium is a preferred mood stabilizer because you really can't give valproate to women. And even when you give it to men, you increase the risk of neurodevelopmental disorders in their offspring. So that's one thing. The second one is we often will add back a little bit of D2 blockade. Usually it doesn't get you much mileage, but it might get you some. So if they're on clozapine monotherapy, that's step 2. And step 3, really your best option more than anything is not a medication, it's going to be ECT. It's hard to do double-blind studies with ECT. Even controlled studies don't show great response, but there's some people who do quite well, and it's a reasonable evidence-based thing to do. Yes, clozapine lowers seizure threshold, but we do not see people who have trouble with this. There's been large case series reported over the decades without a problem, and that's usually where we end up going.
Well, I want to thank you so much for your time today. Thank Saladex for the support for this presentation. And we'll look forward to seeing everyone later in the fall with our next mini webinar. Thank you so much for your time today.
Bye, everyone. Have a good summer.